Good afternoon and welcome back to the auditorium. This is going to be the anti-platelet, conduit and outcome session. My name is Bill Kamani. I'm a consultant cardiac surgeon at the Liverpool Heart and Chest Hospital. Also moderating with me, we have Mustafa Zakar, who is a associate professor at Leicester, and Sigrid Sandner, who is associate professor in Vienna. Just to remind you, the question and answer sessions can be entered by putting text into the chat box on your right, and in the same area there is the voting for each presentation, which is open for about 30 seconds after the presentation has finished. So without further ado, I'm going to have Shireen Ajab, who's going to be presenting on dual antiplatelet therapy guidelines for emergency CABG.
Platelet therapy guidelines for patients undergoing urgent or emergency coronary artery bypass grafting, a review of compliance and impact on the risk of postoperative cardiac tamponade. The 2016 American College of Cardiology and American Heart Association joint guidelines recommend dual antiplatelet therapy in patients undergoing coronary artery bypass grafting as an urgent or emergency case. The 2017 focused update by the European Society of Cardiology in collaboration with EACTS provides a Class 1 Level C recommendation for dual antiplatelet therapy in acute coronary syndrome patients undergoing coronary artery bypass grafting. The benefits of dual antiplatelet therapy with regards to reduced vein graft occlusion and 30-day mortality have been well established. However, there are potential risks of bleeding which may require a restenotomy. Restenotomy for cardiac tamponade or persistent mediastinal bleeding is associated with higher rates of blood transfusion, renal replacement therapy, and increased mortality. The objectives of the study were to determine the bleeding risk of dual antiplatelet therapy in urgent and emergency coronary artery bypass grafting patients compared with aspirin monotherapy. In addition, it set out to review the current departmental compliance with the 2016 guidelines by the American College of Cardiology and American Heart Association. A two-stage study was conducted. Initially, a case control study was performed, comparing patients with aspirin monotherapy and those that received dual antiplatelet therapy. In addition, a retrospective review of dual antiplatelet therapy compliance was conducted. All patients having undergone urgent or emergency coronary artery bypass grafting were included. Data for the aspirin monotherapy cohort was collected between January and December 2015 and compared with patients having received dual antiplatelet therapy between December 2016 and January 2018. Dual antiplatelet therapy compliance was reviewed between August 2019 to August 2020. The primary outcome was re-exploration for bleeding, and secondary outcomes were compliance with the guidelines, length of hospitalization, 30-day and 1-year mortality. All data was analysed using SPSS version 26. In total, 246 patients underwent urgent or emergency coronary artery bypass grafting, 123 patients received aspirin monotherapy, and 123 patients received dual antiplatelet therapy. The baseline characteristics were comparable in both cohorts with regards to gender, cardiovascular risk factors, and the number of coronary arteries affected. However, median age was statistically higher in the dual antiplatelet cohort at 71 years, compared with 68 years in the aspirin monotherapy group. There was no statistically significant difference in the rates of cardiac tamponade between the two groups. There were 9 cases of cardiac tamponade in the aspirin monotherapy group and 8 cases in the dual antiplatelet group. There was no difference in the length of intensive care stay between the aspirin monotherapy and dual antiplatelet groups. There were no differences in the overall length of hospital stay. 30-day and 1-year mortality were the same in both arms at 0.8%. The retrospective review of compliance included 163 patients with an average age of 65 years. The average length of hospitalization was 8 days, and there was a 4% rate of restenotomy for cardiac tamponade. There were no in-hospital mortalities. There was a 95% rate of compliance with the dual antiplatelet therapy guidelines, and the majority of patients received ticagrelor in combination with aspirin. In conclusion, there was a high departmental compliance with the current guidelines. There is no increased risk of bleeding in patients undergoing urgent or emergency coronary artery bypass grafting on dual antiplatelet therapy compared with aspirin monotherapy. There was no difference in the length of hospitalization, and early and long-term mortality were the same in both cohorts. The study is limited by its small sample size and results from a single centre. However, further multi-centre studies may allow these results to be validated.
So questions from the moderators. Sigrid, do you have anything that you'd like to ask?
Sure. So Shireen, very nice presentation,
You're still muted,
very well presented. I wanted to ask you, do you withhold P2Y12 inhibitors preoperatively? So were in any of your patients, was the P2Y12 inhibitor withheld preoperatively, or do they all undergo surgery on dual antiplatelet therapy?
Yes, so we do routinely withhold for 5 days, except in patients that have got critical left main stem disease, in which case then it's down to the individual surgeon, but we usually then continue it in those cases.
Okay, and how do you? What is your practice post-operatively? Because you showed that. I assume what you meant by departmental compliance. I assume that you mean adherence to dual antiplatelet therapy preoperatively after acute coronary syndrome. What is your practice post-operatively, and when do you reinstitute the P2Y12 inhibitor?
So we don't have a standard protocol. It's usually assessed on a case-by-case basis, depending on when the patients are usually the bleeding settled down and obviously the drains have been reviewed. So it's usually a case-by-case basis, and it tends to vary in our institution, surgeon to surgeon.
But it is reinstated as per the guidelines?
Yes, if there's no contraindications, then they're reinstated.
Perfect. Great.
Can I ask you a couple of questions, Shireen?
Yes, of course, Professor.
So thank you very much for this presentation. It was really great.
Thank you.
My understanding that you compared two groups. One of them had the aspirin only to another group who had this dual antiplatelet treatment. But this was not at the same period of time. It was a different period of times. Is that right?
Yes, that's correct. So we compared the patients that had just the aspirin monotherapy were those patients that had already undergone surgery with the existing guidelines. And we then compared it with a cohort that had received dual antiplatelet therapy, but had also undergone urgent or emergency coronary artery bypass grafting after the introduction of the new updated guidelines.
Okay, so you compared an old cohort with a new cohort after the introduction. Great. Okay, so how many days do you usually stop your ticagrelor or your clopidogrel before surgery?
So in our unit, we usually stop it for 5 days preoperatively.
Okay, and you do that routinely regardless of what the drug is?
Yes, usually it's routine. Yes.
Fantastic. And one final question. You mentioned that there was no differences in terms of bleeding between the two cohorts. And I presume you are talking about the first 24 hours before, after surgery, isn't it?
Yes, correct. Yeah.
So the exploration in theater was due to bleeding or due to tamponade only?
Yes, correct. That were the endpoints that we looked at, yes.
Okay. Thank you very much. Fantastic presentation.
Thank you.
Great. So we'll move on to the next presentation, which is in-hospital outcomes and 20-year survival in patients with impaired LV. And this is going to be presented by Eterino de Tomas.
Hello everyone. My name is Eterino de Tomaso. I'm one of the cardiothoracic registrars at the Bristol Royal Infirmary, and I would like to thank the SCTS for the opportunity to present this project today. The topic of my presentation is a retrospective analysis of our 20 years experience at the Bristol Heart Institute with patients with reduced left ventricular function underwent coronary artery bypass grafting. This group of patients, the ones with moderate or severe impairment of left ventricular function, still represent high-risk group of candidates for myocardial revascularization, associated with higher risk of mortality and morbidity. Therefore, the aims of our analysis were to study the short-term in-hospital mortality and long-term survival up to 20 years in patients with moderate or poor LV after CABG, to identify the predicting factors of poor clinical outcomes, to evaluate the impact of incomplete revascularization and bleeding heart surgery on early clinical outcome and late survival, and finally to assess how good is the Euroscore to predict the early and late mortality in this selected population. As I said, this was a retrospective analysis conducted at the Bristol Heart Institute covering a period of time from 1996 to 2015. During this time, more than 50,000 patients underwent CABG and more than 5,000 had a reduced LVEF that we divided in moderate or severe dysfunction. On the right, we can see the primary and secondary endpoints of our analysis. These are the baseline characteristics of our population. We had 5,016 patients with a mean age of 68 years old. More than 80% were males, and up to 25% of the patients had diabetes. It's quite important and needs to be highlighted that 57% of the operations were non-electives, so conducted in an urgent or emergency setting. And these are our results and our survival. At 30 days, our survival rate was 95.6%. At 1 year, our survival rate was 91.1%. 10 years was 55.1%. And at 20 years, our latest follow-up, more than 22% of the patients were still alive. And this was quite a good result from our point of view. Then we evaluate the impact of complete versus incomplete revascularization or long-term survival. And as you can see, patients who had a complete revascularization, meaning all the disease vessels were grafted, had a better long-term survival compared to ones who had an incomplete revascularization. And this difference was statistically significant. Next, we look at the use of cardiopulmonary bypass machine, and we didn't find any major difference on long-term survival between patients who had a non-pump surgery versus the ones who had an off-pump surgery. Then we evaluate the reliability of Euroscore, and we found out that the Euroscore is less reliable in predicting mortality in patients with impaired LV function. In fact, it tends to overestimate the risk of mortality compared to patients who have a normal LV function. And finally, with a Cox hazard ratio model, we identified the predicting factors of poor clinical outcomes. And as you can see, the most important ones are definitely the incomplete revascularization, a recent acute myocardial infarction, the diabetes, and the poor LVEF. In conclusion, this study shows that CABG can be undertaken with low rates of in-hospital mortality and very good long-term survival in patients with reduced LV function. That the incomplete revascularization has an impact on long-term survival, whilst the use of cardiopulmonary bypass machine hasn't. And finally, that the Euroscore is not completely reliable in predicting mortality in this specific subgroup of patients. We can also say that nowadays, the surgical revascularization should be considered as first-line treatment for patients with reduced LVEF. Also, if we consider that recent literature is showing that PCI stenting is associated with worse outcome in this patient, and this is quite important in decision-making where we have to deal with patients with poor LVEF. Thank you very much for your attention.
Question for you in terms of defining completeness of revascularization. Did you simply use 1, 2, and 3 vessel disease and the number of grafts to define whether the patients were completely revascularized, or did you use a more detailed and granular data set? So, for example, syntax score, number of branches.
We relied on our internal data set. So obviously, we couldn't go too deep into how many grafts the patient really needed at that time. So obviously, if on our data set, we had a patient who signed off with a triple vessel disease and that ended up with 2 vessels bypassed, we consider that incomplete. Obviously, it's not very precise, as you can imagine, but for to speed up the analysis, that what we looked for at that time. Obviously, we would like to go more deep into this because I think it's quite important.
Yeah, it would be a nice project for the future.
Yeah.
Thank you. Mustafa, would you like to lead in the next one? Thank you.
Yeah, thank you. So I just wanted to add to Bill's point, because really I think reporting incomplete revasc is a big thing to say in your abstract, because you don't really show any complete revasc or incomplete revasc. What probably you've done is based on what the group published in 2016, and it is the number of vessels that have been grafted. which again, we know that it means nothing in terms of completeness of revasc. My question to you is really regarding the on-pump and off-pump. So you're saying incomplete revasc is associated with reduced mortality, but there's no difference between on-pump and off-pump. Now, how many of these patients who had the off-pump had complete or incomplete? Did you look into that?
No, we didn't yet, Professor Zakaba. We didn't yet. It's actually something we need to investigate further, definitely, because obviously this is just a preliminary screening of our data set. But I think we need to look more into in this. So we didn't actually.
No, that's fine. Thank you very much.
Thanks.
We do have a question that has come in, but unfortunately, I think we're going to have to move on in the interest of time and maybe come back to that later. So the next presentation is second conduit choice impacting long-term survival by Thomas Sinek.
Dear colleagues, dear moderators, it's my pleasure to present you this work about the second conduit choice in multiple coronary artery bypass grafting and its impact on the long-term follow-up of our patients. It has been well established since many years now and is one of the few strong recommendations in cardiac surgery that the use of the left internal thoracic artery to the LAD can improve life expectancy compared to the vein graft. When we think of multiple arterial or vascularization, however, there is obviously in our mind this recent trial trying to show the impact of bilateral internal thoracic artery grafts versus single thoracic artery grafts. Unfortunately, it didn't show an improved survival in the intention to treat analysis. It needs to be stressed, however, that there were some issues regarding the enrollment and the analysis, with many crossover and more than 20% of patients who received a single internal thoracic artery had a radial artery as a second conduit. If the analysis is performed as treated, a significant benefit from multiple arterial grafts was observable. Finally, this trial concluded the need for further studies of single versus multiple arterial grafts. Looking at the European recommendations from 2018, the Lima 2 LAD is once again a stronger recommendation. An arterial graft is to be considered in appropriate patients, depending on the patient's life expectancy, risk factors for sterile wound complications, coronary anatomy, degree of target vessels stenosis, graft quality, and surgical expertise. Radial artery is presented to be recommended over saphenous vein graft in case of severe coronary stenosis, and bilateral internal mammary grafts should be considered if the risk of deep sternal wound infection is not high. So finally, the recommendation for another artery as a second conduit is depending of specific situations and surgical assessments. There is, however, a trend to encourage the use of arterial over vein grafts. In our study, we tried to assess the benefit of harvesting an arterial graft as a second graft. We included every consecutive patient operating on between 2003 and April 2013, and we benefit from a first isolated multiple coronary artery bypass grafting. 6,960 patients were this way included. Redo surgery, preoperative dialysis, off-pump bypass, and no use of the left thoracic artery were exclusion criteria. This is a retrospective monocentric cohort with a prospective follow-up. The outcome was a global mortality regardless of the etiology. Median follow-up was 11.4 years, ranging from 0.1 to 16 years. Now looking at the patient characteristics, there were obviously some differences between the three groups. In the group who received no arterial conduits, the patients were older, more female, body mass index was lower, insulin therapy was more frequent for diabetic patients, and left ventricle ejection fraction was lower. The main differences remained in the priority and the logistical score. Patients with arterial conduits were more frequently elective patients with a lower risk of perioperative mortality. For the surgical procedure, there was no big differences, with slightly more cross-cramping time in patients who underwent arterial grafting. The multiple analysis took into account the age of the patients, the gender, the diabetic status, the preoperative left ventricle ejection fraction, and the body mass index. Regarding the long-term prognosis, there was a significant benefit of choosing an arterial conduit for the second graft rather than a saphenous vein graft, with an hazard ratio of 0.84. You can see here the long-term survival according to the revascularization strategy. More than half of the patients were followed at 10 years. One arterial conduit was systematically the Lima to LAD and shows an improvement of the patient prognosis after 5 years compared to the group without arterial conduits. If the choice of the second conduit was now an arterial graft, either radiatory or RIMA, the survival was even better and statistically significant, with a 10-year survival of 76.4. In conclusion, there are evident limitations in our observational study. The choice of the specific revascularization strategy for a patient is often subjective and may be affected by important confounding factors unavailable to us. For example, the size and quality of the coronary targets or the patient frailty were not documented in our cohort and may influence the long-term survival. Nevertheless, with the long-term survival, we found a significant impact of the revascularization strategy on the patient prognosis. Lima to LAD improved the long-term survival, and the choice of an arterial graft for the second conduit remained in our study associated with a better outcome. Thank you for your attention.
Okay, great. Thank you very much. Can I ask you about what do you use for your radial artery as the fluid for preservation?
Which side you said? Oh,
Sorry?
sorry, I didn't understand the question.
So what do you use as a fluid where you preserve your radial artery after harvesting?
We put it on calcium inhibitors, papaverine, for the Lima and the Rima. We do the same.
Okay, so you don't put anything specific. You don't put GTN on it or anything.
No.
Okay, and I presume for the patient where you do multiple arterial grafting, you end up doing a lot of sequential and Y grafts.
Yes.
So do you think this has an impact on the long-term patency and mortality, maybe long-term?
Maybe because it's a retrospective study, so obviously we have some bias, and maybe it is affecting, even if we didn't find any difference or obvious difference when using a while rather than doing two different distal anastomosis.
Okay, great. Thank you very much. Any other question?
I have a question, actually.
Please go ahead.
I noticed that you have quite a number of patients who did not receive any arterial graft. In what sort of circumstances would you choose not to put an arterial graft, any arterial graft?
Yeah, I know exactly. I had the same feeling when I look at this 1 decade old cohort. We have many patients with only veins, and it obviously was dependent of the surgeons, but it was most of the time because of risk of deep wound infection, rather than not possible to harvest the Lima or the Rima.
Mm-hmm.
It was on the surgeon preference.
Okay.
Great. So we'll move on to the next talk, which is a UK national survey to look at conduit choice by Renier Vester.
Hello, my name is Adrian Visser, and today I will be discussing a project on conduit choice in coronary artery bypass graft surgery, a UK national survey to evaluate cardiac surgeons' perspectives. Conduit choice has always been a main focus in cardiac surgery research. So far, we've determined that the left internal mammary artery has the best long-term outcomes. However, we're currently trying to determine what the second best conduit is and whether it's venous or arterial. At the moment, the evidence is mixed. It's slightly leaning towards arterial being a bit better. However, venous conduits are still more commonly used. Our objectives were to gain qualitative data on the conduit choice decision-making process and to identify any factors influencing surgeons' preference or any barriers that they face in using the ideal conduit. We circulated an anonymized survey to all cardiac surgeons in the Society of Cardiothoracic Surgery registry, 182 in total. It consisted of 15 questions, and we collected data over 2 weeks' time. We received 39 responses. This table shows all the blood vessel conduits that the surgeons have used. Lima coming in unsurprisingly as the most common, secondly with the right internal mammary artery and the radial artery, and thirdly coming with the great saphenous artery, despite its supposed more common use. In questions 6 to 9, we were comparing venous versus arterial conduits. 56% of participants felt that venous conduits were easier to harvest. 51% felt that higher perioperative complications were found in arterial conduits. 74% felt that there were higher post-operative complications in venous conduits, and 94% felt that there were better long-term patency rates in arterial conduits. In questions 10 to 13, we were trying to look at the perspective on the use of arterial conduits. 64% felt that the use of arterial conduits were justified despite potential complications and the difficulty in their retrieval. 61% felt that the use of venous conduits was still justifiable despite the current increasing in life expectancy and any potential low long-term patency rates of the venous graft. 74% of the surgeons did say that they would use arterial conduits preferentially if the evidence was more convincingly strong in terms of long-term patency, and if there was improved training for additional arterial conduits. We looked at the factors which surgeons use to determine their conduit choice. The three of the most common factors were patient coronary anatomy, patient comorbidities, and patient prognosis, all being patient-specific factors, showing how each case needs to have a unique decision-making process that tailored to the specific patient. We've noted that half of the surgeons did not use guidelines in helping them make the decision, which clearly shows that our guidelines are not able to be used effectively within clinical practice. When looking at what may influence how a surgeon changes the way they perform a CABG surgery on a specific day, the most common finding was surgical findings during the procedure. Again, guidelines were shown to play a very insignificant role in the decision or in changing the way a procedure is performed. In conclusion, we found that not only is there a significant variation in practice when considering which conduits to use, but there's also a variation within the perspective of which conduits are better and which are not. We found that patient-specific factors and surgeons' experience play a major role in conduit choice decision-making process. We found that we need better models or better guidelines to help guide the decision-making process in the UK. And further research is needed to explore barriers that are preventing the optimum conduit choice and how to reduce these barriers. Thank you very much.
Great, thank you very much. Can I start probably by asking you about, you were talking about the complication associated with the graft that been harvested and operative complications. Do you mean in terms of wound infection when using vein graft, or in terms of more kind of adverse things such as myocardial infarction perioperatively?
So that was one of our limiting factors in our study. Without making the questions too elaborate or having too many questions, as in the survey, you don't want too many, otherwise you struggle to get feedback. But yeah, it was quite vague in that regard. We were thinking more about like arterial spasms or so forth, or for instance, like sternal wound infections or so forth. But yes, the not having the specificity is one of our limitations.
That's fine. Thank you very much. Any of the moderators has any question to ask?
That's Mario. Can you hear me?
Yes, I can hear you.
Yeah, so that's a fascinating survey. I think I just want to congratulate you because honestly, I don't think we need more evidence in terms of patency. I think we need to understand why the evidence is not enough to convince the surgeons. And so probably we need to shift our attention in terms of research from the conduits to those who are supposed to be using the conduits, the surgeon. Unfortunately, even in your case, the response rate to your survey was pretty low, and that is a major limitation. So just, a plea for everyone, we should really spend some time when we get to those survey trying to answering those questions, because it's the only way to generate important evidence that can potentially change practice. So congratulations on a very, very important piece of evidence.
Yeah, and it was also just to show that the guidelines clearly aren't being used by the surgeons. So like you say, if we need to tailor it to the surgeons.
Yeah.
Great, fantastic. Thank you very much. Any other questions? No, in this case, then we will move to the next presentation, which will be given by Rizwan Attiya about the impact of off-pump and on-pump coronary artery bypass grafting on mortality in octogenarians. Over to you.
Hello, I'll be presenting on the impact of off-pump and on-pump coronary artery revascularization in hospital mortality and midterm survival amongst octogenarians. This work was carried out at Harefield Hospital. Over the last 30 years, there's been a debate within cardiac surgery on the role of off-pump coronary surgery. This is despite 115 randomized trials and over 60 meta-analysis, and many reviews such as this, looking at the role and indication of off-pump surgery. We sought to look at octogenarians who are being increasingly referred for surgical revascularization in terms of outcomes of in-hospital mortality and midterm survival in the off-pump cohort. We retrospectively analyzed prospectively collected data from the patient analysis and tracking system for all first-time isolated CABG patients where at least 2 grafts were performed from 2000 to 2017. Within this cohort, 566 patients underwent surgery, of whom 374 had off-pump and 192 on-pump surgical revascularization. When we look at the results in terms of demographics and preoperative characteristics, we can notice that there are no differences between the two groups, with a similar proportion of patients in terms of age and comorbidities such as diabetes, renal disease, cerebrovascular and peripheral vascular disease, or indeed the same number of patients with triple vessel disease, left mainstem involvement, and poor ventricular function. When we look at the surgical procedures over time, we see an increase in number of off-pump cases up to 2011, and thereafter the numbers plateaued. If we look at the grafting strategy, there are differences between the two cohorts. There's a number of increased patients who had bilateral mammary arteries go up from 11.5 in the on-pump to 31.3% in the off-pump group, increased number of sequential and Y grafts, and arterial grafts to the right side, all of which are statistically significant. If we look at the complication rate, there's a reduced neurological complication rate from 5.7 to 2.1% in the off-pump group, which does not reach statistical significance. However, when we look at the hemodialysis infiltration rate or 30-day mortality, these reduce in favor of the off-pump group in both cases. When we analyze the Kaplan-Meier survival curve, there's a divergence in favor of the off-pump group, which is maintained out to 1 year and indeed 5 years, and these results are statistically significant. When we look at the overall groups in terms of all the patients, this is from a paper published in the European Journal, off-pump coronary surgery was associated with lower 30-day mortality compared to the on-pump group with similar short and long-term outcomes. And the takeaway message from this for us was that experienced surgeons in high-volume centers can achieve same outcomes as on-pump coronary artery surgery. In terms of octogenarian patients, we believe that both strategies are effective for myocardial revascularization. The lower in-hospital mortality might be explicable by the avoidance of cardiopulmonary bypass and hence reduced neurological and renal complications. The improved midterm survival might be explicable based on increased bilateral mammary usage and increased arterial grafts to the right side. We acknowledge that this is a single-center retrospective experience of non-randomized design, and hence might not be reproducible or generalizable to other populations. There's also a lack of angiographic surveillance follow-up for the grafts. However, we believe that there is enough signal from our data to demonstrate that within the subgroup of octogenarians as a patient population, the benefits of off-pump surgery might be tangible when cardiopulmonary bypass is avoided. I would like to thank you all for your kind attention, and I'll be happy to take any questions that you have.
Fantastic, Razwan. Thank you very much.
You're welcome.
So I just wanted to ask you actually about a point, but you raised it already in your discussion, and it was about, I noticed that more of the off-pump patient had arterial grafts, multiple arterial grafting, and I thought whether you guys need to do some kind of analysis where you compare in this subgroup the total arterial or multi-arterial compared to the single arterial and see whether this effect is to do with the off-pump itself or to do with the use of multi-arterial grafting.
Yeah, so as you mentioned, we feel that certainly the data, even in octogenarians going out to mid-term and long-term, would be explicable due to the increased arterial grafting strategy for those group. That probably is the reason for it. Although when we look at the Kaplan-Meier, there's an early divergence, and that the initial benefit probably is to do with a reduced renal complication rate, slightly reduced incidence of neurological complications due to non-manipulation of the aorta. But the continued benefit, as you say, would probably be due to the arterial grafts. So yeah, that's probably something worthwhile delineate to burrow down further into the data, so comparing it to the on-pump cohort. And certainly we feel the arterial revascularization facilitates the off-pump strategy, certainly in our hands.
Can I ask you another question? So at what age in these octogenarians you feel a little bit cautious about using a radial or using a REMA?
I mean, we avoid bilateral mammaries generally in the usual cohort of patients. If you have a obese, diabetic, female, we would want to avoid a bilateral mammary, but there is no age cutoff per se at all at our unit. We feel that the benefit of arterial grafting outweighs the risk in a small cohort of patients. So as long as you judiciously avoid the patients who are the highest risk of deep sternal wound problems, we haven't seen any issues with bilateral mammaries or indeed radial grafts, providing there's a tight stenosis and we don't worry about competitive flow, then we feel that's a good grafting strategy.
Fantastic. Thank you very much. Fantastic presentation. Any questions from the moderators?
Well, no, I think that was a great presentation. Maybe my question for you is, what's your default strategies in your unit? It's off-pump, multiple arterial grafting, your routine revascularization strategy?
Yes. So of the surgeons who do the off-pump, they perform off-pump in all the cases. We try to use as many arterial grafts as we can for our cohort of patients. The second conduit choice usually is a REMA or a radial, and we do a lot of sequential grafts as well using those. So yeah, that's whenever we can, that's our strategy.
So that's really great on a surgical perspective, and congratulations to you and your colleague. This is definitely not average, at least in the United States. On the other hand, on a research perspective, that clearly introduces a bias in your work, because there must be a reason why you decide to put a patient on pump, and that reason is generally not well captured in our database. So statistical adjustment is usually in observational study that compare different technique. Statistical adjustment is usually unable to neutralize the treatment allocation bias that I mean, we call it bias on a research perspective. On a surgeon perspective, it's just the right thing to do because you want to do the right operation on the individual patient. But then when you compare them, remember that you are comparing the different patients who received a different operation. So the outcome is most likely different because of the difference in patients characteristic rather than in the intervention per se. But having said that, it is an intrinsic limitation of all observational study. Your series is really interesting and important, and I want to congratulate you and all co-authors for such an important work.
Thank you very much.
Fantastic. I think if there's no more question, we'll move to the next talk, which will be a meta-analysis, systematic review about skeletonized or pedicled harvesting of the lemur. And it will be,
Hello, my name is Tuberkusu Orkar, and I'd like to thank the SCTS for the opportunity to present my systematic review and meta-analysis looking at skeletonized or pedicled harvesting of the left internal mammary artery, which we'll refer to the lemur from now on. So the lemur conduit produces excellent patient outcomes, particularly when grafted to the left anterior descending artery. However, there's currently significant variance in which technique is used to harvest the lemur, either the pedicled or skeletonized technique. And this is due to the lack of quantitative information comparing these two methods. This systematic review aimed to compare these two methods and provide more quantitative information that will allow surgeons to make a more informed decision. We conducted our systematic review using all the major databases from inception to January 2020. We included studies reporting short-term outcomes and excluded studies not reporting solely on lemur outcomes separate to BEMA or REMA outcomes. Our primary outcomes were post-anastomosis flow rate and graft length. Our secondary outcomes include sternal wound infection rate, acute myocardial infarction, and 30-day mortality. A total of 13 studies were included in our analysis, which totaled 6,222 patients, of which diabetes was the only preoperative variable that was significantly different between the skeletonized and pedicled groups. We found that the skeletonized group had a significantly longer graft length when compared to the pedicled cohort. The forest plot you can see here favors the lower number, which in this case was the pedicled group. We also found the skeletonized group had a higher post-anastomosis flow rate in comparison to the pedicled group, once again, the forest plot favoring the lower number. Nonetheless, we found no difference in the mortality rate or sternal wound infection rate between the skeletonized and pedicled groups. So in summary, we found that when compared to the pedicled cohort, the skeletonized harvesting had higher post-anastomosis flow rate and longer graft lengths, with no significant difference in the mortality rate or sternal wound infection rate. So the increase in graft length allowed for more opportunity for distal anastomosis and sequential grafting for our patients. And the increased post-anastomosis flow rate may be beneficial for reducing sternal wound infection rate. However, we didn't see this in this study. So does this not translate to mortality or better sternal wound infection rates? Well, we believe the benefits that we've seen in the skeletonization here have not translated to these mortality sternal wound infection rates, perhaps because of the short-term focus of this study. And it would be interesting to see if these further translated in a more longer-term study. This systematic review meta-analysis did have some limitations. Most of the eligible studies were cohort studies, and only 4 randomized controlled trials were included out of 13. However, most of these cohort studies were prospective in nature. There was significant heterogeneity in the operative and postoperative factors, as you may have noted the high I-squared value in the forest plot. This is partly due to surgeon choice being a deciding factor in which method to use. And also many of the studies didn't include what specific target, say Lima to LAD, was actually being studied for a specific grafting method. Also, we only looked at short-term results, as I mentioned before. And although this is still important for our patients and still provides valuable information, it would be useful and interesting to see what the outcomes were in a 1, 5, 10-year study. So from the outcomes that we have found in this study, we believe the skeletonized method should be adopted for harvesting the left internal mammary artery. Thank you very much for listening. And thank you very much to all the authors in this paper that made it possible. You can read the full paper in the Seminars of Thoracic Cardiovascular Surgery. Thank you very much.
Thank you very much for this presentation. Any questions from the moderator? Mario?
Well, no, I think that was a nice work. I mean, as someone that has done meta-analysis for many years, I have just a technical suggestion for you. You should probably change the labeling of your plots because they are a little bit confusing when you read them. But apart from that, I think what you found make biological sense. You highlighted very well the limitation of your meta-analysis, and I think you did a very good job and provided important information. So congratulations.
Thank you very much. Yes, the review manager automatically makes the plot look.
I know. So you just put them like in a PowerPoint presentation and change the labeling. We have in this kind of meta-analysis, if you use RevMan, that's what happened. But you know, for the reader, in order to make it more understandable, it's probably better to switch.
Okay, we'll do in future. Thank you.
We have one question from the audience, and they are asking about: have you looked at the methods of Lima harvesting, such as diathermy, harmonics, scalpel, scissors, etc.?
Yeah, most of the studies in the meta-analysis use diathermy to harvest the Lima, whether it's skeletonized or pedicled. There wasn't we didn't find any differences across the studies with that.
Fantastic. Thank you very much. Any other questions from the moderator, Bill or Sigrid? Okay,
Thank you very much.
Great, well done. So we'll move to the next one. The next one will be by Terence John Donovan about factors determining perfect vein graft patency at 2 years.
Dear chairpersons, colleagues, and ladies and gentlemen, thank you for the opportunity to present these data gleaned from the VEST-3 trial, which was recently completed. This was a multi-center international effort, and I would like to mention all of the fantastic people who worked on the study. The saphenous vein continues to be the graft of choice in the vast majority of coronary vessels that we revascularize. The reasons for this are complex, but the fact remains that many venous grafts are being put into patients every day that are susceptible to failure over time. Now, just how these grafts fail changes over time. Very early failure is generally due to technical issues. In the literature, this rate runs at about 10%. After this initial drop-off, venous grafts begin to fail as a result of degeneration at a rate about 5% per year. The purpose of this analysis was to use data from the VEST-3 study to look at this along a timeline from 6 to 24 months following CABG to try and identify correlates. The results from the VEST-3 study are currently in the process of publication. It's a prospective RCT that was designed to look at the effect of external venous graft stenting. Its protocol called for the intraoperative randomization of an external stent for the venous graft to either the right or the left territory of the same patient. These patients were then looked at with CT angiography at 6 months to probe for early failure. Those patients with at least one patent venous graft went on to get coronary angiography at 2 years, and of those patients, a pre-selected group had concomitant IVUS to look closely at possible differences in the intimal hyperplasia between stented and non-stented venous grafts. For those of you who might not be familiar with the vest, the image on the left shows the device. The central image shows the device in situ on the vein to the right coronary artery. On the right, we see in the upper image the angiographic aspect of a stented vein to the left marginal territory, and on the lower image, we see a non-supported venous graft to the right coronary artery. Please note the high degree of luminal regularity of the supported graft compared to the unsupported graft. Let me now give you a better look at the device in situ. For our sub-analysis, we had CTA imaging data at 6 months on 166 patients that showed an overall patency rate of 88.8% and also 128 coronary angiograms at 24 months. 51 patients also got IVUS during their angiography. Since overall patency was about 88% at 6 months, we decided to use this number as a cutoff to delineate between superior and inferior patency rates. We then took the analysis down to the surgical center level and stratified. We found 9 centers that achieved superior patency and 5 centers with inferior patency rates. Then we looked at the baseline data and other granular data on surgical technique and other variables to look for correlation. We looked at the usual group of suspects and we were unable to find any significant differences between patients from inferior and superior patency centers. However, at the level of operative technique, we saw some highly significant differences. In the superior patency group, the vast majority of veins were harvested with an open technique, and in the inferior patency group, almost 2/3 of the grafts were harvested endoscopically. We can also see that almost 50% of the veins in the inferior patency group were coming from the thigh, while that was true for only a small number of cases in the superior patency group. Here are the 2-year data on Fitzgibbon patency and intimal hyperplasia. In the SEP centers, we saw a much larger percentage of stented grafts with perfect patency when compared to all other groups. This finding is repeated when you look at intimal thickness data from the 51 patients who got IVUS at 2 years. Stented grafts from SEP sites have, by far, the thinnest intimal layers when compared to all of the groups. This is possibly the substrate of their efficacy. And indeed, if we look at patency loss in grafts from both IEP and SEP centers, we find that although early patency in SEP centers was much higher for both stented and unstented grafts than was the case for IEP sites, at 2 years, we did see significant continued loss of patency. But if you look at the results from the stented grafts from SEP sites, this loss of patency was minimized. To summarize, superior early SVG patency is seen in centers that use an open technique to harvest veins from the lower leg. The exact opposite was seen in centers that use EVH to harvest veins from the thigh. At 24 months, stented grafts from SEP centers showed only minimal additional loss of patency. Stented grafts from SEP sites also had significantly higher perfect patency rates and a significantly thinner intimal layer. In IEP centers, external stenting had no effect. As with all new technology, there is always a learning curve, and I hope that this analysis will have a positive impact. Thank you for your attention, and I will be happy to try to answer your questions now.
Great, fantastic presentation. Thank you very much. Any questions from the moderators? We can't hear you, Bilal.
Thanks very much. So that's a fantastic presentation. The regroup trial that was recently published suggested that at 3 years, there was no difference between open and endoscopic vein harvest in terms of clinical outcomes. Clearly, this shows that there is angiographic differences between endoscopic and open vein harvest. How do you correlate that with what we know about endoscopic vein harvest? And do you think it will change practice in the States? Presume that Terence is not here to answer any questions. Sigrid, you were a co-author on this presentation.
Yeah, I was part of that project. So obviously the regroup trial didn't have any data on patency. They didn't have imaging. So if you look at those trials that actually had imaging endpoints, I mean, PREVENT-4, I think, and the RUBY trial, those trials or subgroup analyses of trials that have imaging, they tend to show improved patency for open harvest, and trials that look at outcomes tend to show no difference. So I think it's open in that regard, and you'll just have to wait for long-term data to see if the stent actually does improve patency. The VEST-3 trial was not powered to look at patency.
Right.
Absolutely. I think there was a question from the audience. And the question was relating to whether we think the data and better outcome is related to good surgical technique, which is more important than putting the vest itself.
So I see John is online. Yes. John, can you hear us? Do you want to answer? So I'll answer. I mean, technique obviously greatly impacts patency. We know this. And also, if you look at our data of the sub-study, we saw that in those group of patients that actually had lower outcomes or worse outcomes at 6 months and worse outcomes at 2 years, these were patients that had vein grafts harvested from their from the thigh, from the thicker vein grafts, and also had a use of a greater diameter external stent, which is likely a correlation. But if you have normally sized vein grafts and you use a stent which is oversized, the stent is not going to exert that biomechanical effect which is designated to do, because it's supposed to act mildly constrictive. And so coming back to your question, technique, obviously, in using this device, because it's a device, not a technique, is going to have an influence.
Fantastic. Thank you very much for answering, Sigrid. Any other questions from the moderators? No, in this case, we will move to the next presentation. The next presentation will be about the effect of P2Y12R receptors inhibition on bleeding during urgent or emergency CABG.
Dear Chairman, dear colleagues, my name is Andreas Fötsch from the Department of Cardiovascular and Endovascular Surgery here in Salzburg, Austria. And it is a pleasure for me to talk about the effect of P2Y12 receptor inhibition on bleeding during urgent or emergent CABG. Why is this topic of importance? There is a clear association between bleeding and perioperative morbidity and mortality. There is the addition of P2Y12 receptor inhibitors on top of aspirin as a cornerstone in medical therapy in acute coronary syndromes. There is up to 11% of ACS patients who underwent CABG during anti-platelet therapy. There is a class 1 recommendation for the use of the newer agents, and there is only limited data available on the optimal timing of discontinuation when bringing those patients to the OR. So what we did was a prospective trial from 2013 to 2016, where we enrolled all patients who were on dual antiplatelet therapy within the last 7 days, who were referred for first-time CABG with or without additional valve surgery. Exclusion criteria included patients on chronic hemodialysis, patients on oral anticoagulation, those who underwent off-pump surgery, and patients who needed hypothermic circulatory arrest during surgery. Our primary endpoint was calculated red blood cell loss, which accounts for preoperative anemia and takes into account the administration of packed blood cells. The secondary endpoint was a marker of severe bleeding, BARC type 4, CABG-related bleeding. In our cohort, 24% of patients were anemic preoperatively. The baseline characteristics of our patients, we included 299 patients. Patients were in the mid to end 60s. Euroscore 2 was 2.9%, and acute coronary syndrome was the main indication for urgent or emergent surgery. So when regarding the withdrawal time, please note 83% of those patients were treated surgically within less than 48 hours of the last drug intake. There was a standard surgical approach to those patients. Surgery lasted for 240 minutes in mean. Internal memory artery usage was quite low. This is attributable to the early experience where a lot of patients needed to be brought back to the OR for bleeding. And in some of those patients, we encountered bleeding issues from the harvesting side of the IMAs. Concomitant procedures were performed in 9% of those patients. Regarding the endpoints, the secondary endpoint BAG4 bleeding was sustained in 45% of patients with significant differences between the types of platelet inhibitors. The calculated red blood loss differed significantly with increased blood loss in the patients who were treated with the newer generation of platelet inhibitors. Rethoracotomy rate was 11%. Of note, in 55% of those rethoracotomies, a surgical bleeding site was identified. 30-day mortality was 9%. Quite interestingly, the 24-hour chest tube drainage did not differ significantly between the groups. Looking into the details of the endpoints, red blood cell loss differed significantly over time and differed significantly between the groups. And it was significantly higher in prasugrel and ticagrelor treated patients when operated on within 24 hours compared to clopidogrel. For the secondary endpoint BAG4 bleeding, the incidence was higher when patients were treated with prasugrel operated on within 24 hours. And compared to a 0 to 24 hour withdrawal time, discontinuation for more than 48 hours dramatically reduced the incidence of BAG4 bleeding in clopidogrel and prasugrel treated patients and reduced it in ticagrelor treated patients. So let me conclude. Exposure to the newer agents within 24 hours before CABG increases both calculated red blood loss and the incidence of BAG4 bleeding. Prasugrel and ticagrelor increased red blood cell loss. This is corresponding to the administration of 2, respectively 1 units of red blood cells. Compared to a 0 to 24 hour withdrawal time, discontinuation greater than 48 hours dramatically reduced calculated red blood loss by 37 to 48% and the incidence of BAG4 bleeding by 58 to 71%, depending on the used P2Y12 receptor inhibitor. Therefore, our data strongly support the strict adherence to the 2017 ESC guidelines on dual antiplatelet therapy whenever justified by stable hemodynamics and the amount of jeopardized myocardium.
Presentation there. Are there any questions from any of the moderators for Andreas?
Yeah, I'll ask. So, Andreas, very nice presentation. Also, congratulations on getting your manuscript published in the annals, no less. I just wanted to ask you, so you said that about half of your patients had BARC4 patients, and I don't know if everyone is familiar with the BARC classification. BARC4 includes take-back for bleeding, chest tube output, among other things. So you had, I think if I heard correctly, a lot of surgical bleeding as the reason for your take-backs. Does this in any way skew your results? Did you try and exclude those patients?
Actually, thank you for the question, because this was one of the main criticisms. After having a look into the details, there was an institutional protocol for rethoracotomy at the center where the study was conducted. And this protocol included a rethoracotomy if bleeding was more than 1,000 mils, after excluding disarrangement of bleeding factors. And there was a high rate of patients who were brought back to the OR because they had blood loss more than 1,000 mils. And this was the reason why the incidence of PAC type 4 bleeding was that high.
Yeah.
Within those patients, we had a look into the operative notes, and there were surgical bleeding sites described in the operative note. May it be minor bleedings from harvesting sites of the IMAs, bleeding from the sternum, but not that big surgical bleeding issues.
Okay.
Okay.
And one more question, because we know that, platelet reactivity in patients who take clopidogrel is very highly dependent on genetic polymorphisms. Did in your study patients, since I'm assuming that these were planned patients, or I don't know how quickly they went to the OR, did they have any testing for CYP2C19 genetic polymorphism?
Not in general. We concluded 2 study populations in this paper. The first study population was from a study where platelet reactivity was measured, but the second cohort did not receive these measurements.
Okay.
And overall, more than 80% of patients were brought to the OR within 24 hours after diagnosis. So we do not have systematically measured platelet reactivity in these patients.
Okay, thank you.
Great. We've got one question from the floor from David Jenkins. Did you find that mortality was higher in patients who had excessive bleeding? And has this changed your practice?
Yes, we did see mortality was higher in those patients who bleeded. Actually, practice changed since that. We are now way more reluctant to withhold the antiplatelet therapy and wait to bring those patients to the OR because mortality was excessively high. There was a 9% overall mortality in this cohort. Yes, you can argue 95% of patients were in acute myocardial infarction, but I think the mortality was way too high in this cohort.
Okay. In the interest of time, we'll move on to the next presentation, which is evaluation of a simplified method of radial artery harvesting, which is presented by Janesh Nair.
Good afternoon, everyone. I'm Janesh Nair, one of the surgical care practitioners from within Shah Hospital, Manchester University NHS Foundation Trust. Here today, I would like to present one of the studies we conducted in our department, evaluation of simplified method of radial artery harvesting using vessel sealing bipolar diathermy device. The radial artery has a significantly lower risk of occlusion and incidence of adverse cardiac events than saphenous vein graft. Radial artery patency rates at 10 years were 90% and at 20 years greater than 80%. Current guidelines on myocardial revascularization supports the use of radial artery over the saphenous vein graft in patients with a high-grade coronary artery stenosis. Key parameters influencing the long-term patency of radial artery grafts are appropriate patient selection, meticulous coronary target selection, and scrupulous operative technique. Aim of our study was to assess the outcome of radial artery harvesting by the use of ligature in terms of pain, wound infection, and vessel spasm. Background of our study was, traditionally, radial artery is harvested using unipolar or bipolar diathermy as an energy source. We evaluate the ligature exact dissector, which is a vessel sealing bipolar diathermy device for harvesting the radial artery in coronary artery bypass grafting. The ligature exact dissector utilizes bipolar diathermy and pressure to seal and divide tissue and blood vessels up to 7 millimeters in diameter to provide better hemostasis. Methods of our study was, we included all patients that underwent CABG between March 19 to November 2020 using radial artery harvested with ligature. All patients were examined preoperatively and had modified Allen's test performed by the operating team. All patients were followed up for the incidence of complications at discharge and after 6 to 8 weeks. The results, 82 patients identified, 68 of them male, Mean age was 64.76, which varies from 36 to 82 years. 77 patients underwent isolated CABG. 5 patients had a CABG plus valve surgery. 76 patients had a total arterial revascularization. Average number of grafts per 2.89, which varies from 2 to 5. The results, medium time for radial artery harvesting was 29.27 minutes. Those who had a previous experience of harvesting the radials. There was an incident of radial graft spasm, side branch bleeding, no need for additional hemostasis of side branches, no tamponade or re-exploration for bleeding. Average hospital stay was 7.73 days. 11 patients stayed more than 15 days because of different reasons like COVID-19 and other social issues. Radial harvester side complications. There were no symptoms of ischemia, motor dysfunction in the arm postoperatively. 4 patients at follow-up reported that mild numbness around the incision site. 2 patients had redness around the wound. One of them GP prescribed an antibiotic cream for 1 patient, and the second patient GP prescribed antibiotic over phone without direct assessment. In observation, trainees achieved competencies with a ligation excision dissector in 1 session. Advantages including safety, ease of use, time efficiency, and minimal blood loss. In conclusion, the study demonstrates that the ligation excision dissector is safe for radial artery harvesting in CABG with a low rate of complications. We found that the low temperature profile with the fast cooling of the instrument jaws facilitated training. Thank you very much for listening. Thanks to SCTS for giving me an opportunity to present this paper. Thanks to all.
Thank you very much for that talk, Janesh. We'll just see if you come back online to answer any questions. Are there any questions from the moderators? Any questions from the floor? So, Janesh, did you have any comparator group for looking at the ligashore, and what were you using before this?
We were using normal diathermy, the normal diathermy Valley Lab.
And Liga clips?
Yeah. Yeah, diathermy and Liga clips, yeah.
Okay, and when you use the ligashore, do you also put on additional metallic clips? Or do you just use the ligashore?
No, not necessarily. Usually not, but some surgeons is not very much busy, so they will just pick your branches and clip them. Otherwise, usually not necessary.
Great. Okay. Well, thank you very much. If you'd like to log off, then Janesh, or hit the red button, I'm going to present with great pleasure our keynote speaker, Dr. Gaudino, who is the Stephen and Suzanne Rice Professor of Cardiothoracic Surgery at Weill Cornell University Hospital. He is the author of several hundred papers, books. He is the recipient of numerous grants for trials, and really he needs no introduction. Over to you, Professor Gaudino.
Thank you.
Hello. It's a privilege today for me to speak to you on cerebral and spinal cord protection in acute aortic arch surgery. These are distinctly different topics, and I'm going to cover them one at a time during this lecture. So cerebral protection is one aspect of the overall contemporary circulation management strategy used for open arch repair, along with myocardial protection and lower body perfusion. These 3 components constitute the necessary strategy needed for optimal patient outcomes. The key components of a contemporary cerebral protection strategy include the arterial cannulation site, the degree of systemic hypothermia employed, and adjunctive cerebral perfusion techniques. In the 1970s, the primary cannulation site was the femoral artery, and
Yeah, I think the radial artery is a good conduit. It's not as large as a femoral artery. So I was wondering, is that my presentation?
I thought maybe you changed your interest these days.
Yeah. I mean, I have been working a little bit on aortic surgery because, you know, Cornell is mostly it was at least mostly an aortic program, but clearly that was not my presentation.
No, I think we have yours now ready, hopefully.
Great.
No doubt you have got lots of followers who hang on your every word. So I hope that they're not going to, as you say, start using major blood vessels as their conduit of choice under your instruction.
I would not encourage people to use the femoral artery for bypass surgery.
Only because you couldn't get a transit time flow probe around it.
That may be challenging.
That's a good
I agree.
point.
I totally agree on that.
So while we're waiting for your presentation to load up, you've obviously seen a number of different presentations this afternoon talking about different uses of arterial conduits for second, third, and fourth grafts. Is there any situation where you try and steer away very strongly from the radial artery? Because obviously you're a fan of it in general.
Well, that's a great question. Thank you. And I think there are two levels of answer to this question. In general, the radial artery has a clear contraindication. The first and most important is lack of a very clear evidence of good ulnar compensation to radial artery removal. I don't think that having arm complication is acceptable at all. And so there are patients, depending on the method that you use, 10-15% of the patient would not have adequate ulnar compensation. So in those patients, you cannot use the radial artery. In terms of target vessel stenosis, we all know that the radial artery is susceptible to the risk of failure to the competitive flow. So you need a pretty tight stenosis. Now there are different definitions of it, and I think yesterday during the academy we spent some time discussing of what angiography can tell you, what FFR can tell you, but severity of target vessel stenosis is another important indication. Indication of contraindication. And then I have a specific caution in patients who have chronic renal failure and may potentially necessitate an AV fistula in the arm, because clearly in those patients, first of all, life expectancy unfortunately is generally limited compared to the general population, so you may not see the long-term benefit of radial artery use. On the other hand, the use of AV fistula is much better for the patient than an indwelling catheter, and so in this situation you need to really balance the risk benefit, and there are cases where I decide not to use the artery at all.
Thank you. We've had a message through from the AV guys. Do you have your presentation with you? Can you present it from your slides at all?
I do not know. Let me check in my slide folder if I didn't delete it. I can certainly do that if I find it.
And from the moderators, while Mario's having a look for that, are you both radial artery users?
I greatly prefer the second memory, but this is just a personal preference and not based on data.
Okay.
No, I use the radial more than the ream, actually.
Yeah.
What about
Same.
you, Bill? Yeah.
Yeah, I'm a radial artery user, and I basically look for excuses to use it. Unfortunately, the radial first for coronary catheterization by the cardiologists means that quite often the radial is punctured and can't be used. But overall, it's my preferential choice.
No,
So I found a presentation on the radial artery, which was not the presentation I gave here, but it's more or less it's the one that I gave at the AATS meeting. I must acknowledge that. So if there is a way that I can share my slide, my screen, I can probably use that if you are okay. I cannot find the presentation that I prepare for the SCTS. So let me see what happens if I do that. That's the beauty of virtual meeting. Okay, now I'll do.
So they send you a link on the chat.
Yeah.
Okay, while we're waiting for him to come back, again, for the moderators, do you tend to prefer composite? Do you put top end on for your second arterial grafts? Do you think it's important to have an independent input?
As I have declared myself a fan of the beta, my personal preference is also to use separate inflows. So I will use the bilateral mammary in situ if in any way possible.
No, I mean, for me, I use a single clamp, so I do all my operation with a single clamp, so I don't have problem putting bottom end, top end, so I don't usually do much sequential, unless I really have to.
Okay. And when you're using bilateral mammaries, do you cross the midline? Do you put your reamer onto your LAD and use the left for the lateral wall?
Yeah, I also have no problem doing that. Yeah.
Okay. You never go through the. Oh, here we go.
Getting there.
So what do you see now? Let me start. So there are observational studies, as we all know, that suggest that the use of the radial artery rather than the saphenous vein may improve long-term outcome in CABG surgery, including survival. This is a meta-analysis of 14 adjusted observational study comparing the use of the radial artery, the saphenous vein, as a second conduit for CABG, and what we found among slightly more than 20,000 patients was that patient who received the radial artery lived longer at the mean follow-up of 7 years. There was a very clear separation of the reconstructed Kaplan-Meier curves. The problem, and I was mentioning that earlier with those observational study comparing different technique, and that is that as a surgeon, we are trained from the very beginning of our career to tailor our intervention to the individual patient that is sitting in front of us. And so we tend to use a technique that we assume have better long-term outcome in those patients who we believe have a longer life expectancy. So again, in observational study comparing different technique, different patients receive different intervention, and there is very difficult to derive information on the treatment effect of the tested intervention. That's why in 2015, I founded the Radial Artery Database International Alliance that was a merged database of all randomized trials that have compared the radial artery with other conduit using CABG surgery, using individual patient data. Those are the trials that were included in the 5-year clinical analysis. There were 5 trials from Serbia, Australia, from the United Kingdom, Italy, and South Korea. Actually, just for completeness, there was a 6th trial that was included. It was a Canadian trial, the RAPS trial, but it could not be used for clinical evaluation because that trial used inpatient randomization, and so we used the data only for the angiographic analysis of the individual patient meta-analysis. In 2018, we published the result in the New England Journal of Medicine. We found that at 5-year follow-up, there was a statistically significant reduction in the risk of a primary composite outcome that included death, MI, and repeat revascularization in the radial artery arm. That was accompanied and very likely explained by a statistically significant reduction in the risk of graft failure in the radial artery arm. When looking at the individual component of the composite outcome, we found no difference in survival. We found a very clear difference in repeat revascularization in favor of the radial artery that was driving the primary composite outcome. And we found a difference, again, in favor of the radial artery in follow-up myocardial infarction, even though this difference was not adjusted for multiple comparison. So the 5-year analysis were an important signal in favor of the use of the radial artery, but also had very important limitation. The analysis was largely underpowered from the individual component of the composite outcome, and that was mostly because the event rate in the first 5 years after surgery in the CABG population is relatively low. And also you have seen that the revascularization rate that was driving the primary composite outcome was very likely inflated due to the use of per protocol angiography by the majority of the trials that were included in the 5-year analysis. So for this reason, in 2020, we updated the follow-up of the radial database to 10 years. We published the result in the Journal of American Medical Association. The follow-up of the individual trial included in the database was updated to 10 years or to the maximal possible follow-up using different methodology based on the logistic of the individual trial. Our primary outcome consistent with the 5-year analysis was a composite of death, MI, and repeat revascularization. However, we also pre-specified a secondary outcome that was made only of important clinical event, so death and MI, taking repeat revascularization out of the equation. That was not a pre-specified outcome and was analyzed post-hoc. We used a mixed effect Cox regression model. Median follow-up time was 10 years in both groups, and more than 90% of the patients had the 10-year follow-up data available for the analysis. So those are the results. In terms of the primary composite outcome, we confirmed the difference in favor of the radial artery that we saw at 5 years. However, even more importantly, we found that there was also statistically significant reduction in the risk of death and myocardial infarction. So when even when looking only at clinically important outcome, the use of the radial artery was found to be better than the use of a saphenous vein. Death again was not a pre-specified outcome, and this analysis was post hoc, but we also found a statistically significant survival benefit for the use of the radial artery. I think it's important that you note how the two survival curves are almost superimposed for the first 6 years and then start diverging. So this is something that we need to keep in mind. The benefit, the potential benefit at least of a second arterial graft start becoming apparent only in the late part of the follow-up. In terms of individual component of the composite outcome, there was a lower incidence of both MI and repeat revascularization in the radial artery arm, but the statistical significance was reached only for repeat revascularization. At subgroup analysis, female seems to benefit the most from the use of the radial artery, a finding that was consistent with the 5-year analysis. We also perform a time-segmented analysis to try to evaluate the effect of using a per protocol angiography during the first 5 years of the follow-up by the majority of the trial. And in fact, we found that the difference between arm in repeat revascularization was clearly different between the first 5 years and the second 5 years of the follow-up, but these did not affect the main result of the trial, because the difference between group in the primary composite outcome was statistically significant both in the first and in the second 5 years of the follow-up. So my conclusion that among patients undergoing bypass surgery, the use of the radial artery compared to the use of the saphenous vein was associated with a lower risk of a composite of cardiovascular outcome and better survival at 10 years follow-up. I think it's important to highlight how the analysis of the long-term follow-up of the radial is the first report of a survival benefit for bypass surgery using multiple arterial conduits that is based on randomized data. And that is particularly important because of the intrinsic treatment allocation bias in observational study that I mentioned at the beginning of this presentation. So based on the current available evidence, the radial artery is the best second form conduit for CABG. I'm sorry for Sigrid. And is the only conduit other than the ETA-LAD to have a class 1 indication. And having said that, I thank you all for your attention, and I hope I am able to stop sharing now. I don't think I am able to. Let me see.
No, you're back on. You're back
Okay,
online with us.
I did it.
Well, first of all, thank you very much for an astounding presentation there. I think we'll all agree that was a lot of very, very comprehensive data there. I have a lot of questions, so what I'm going to do is I'm going to bite my tongue for a moment and see if there's anybody else who would like to ask any questions from the other moderators to start with.
But Mario, was a great presentation, as always. And I just want to say, you know, I'm astonished because, you know, the 10-year data that you present, you have a significant result for the composite primary endpoint. You have a significant result for your composite endpoint of death and MI, and you show a significant benefit for death, even though it's a post-hoc analysis. So, you know, we were discussing before with that presentation that did the survey, I mean, how much more evidence do you need? And it's really unfortunate that evidence alone does not seem to convince surgeons to change their practice. So I think all of us are going to have to make a considerable effort to convince people just, you know, to change their behavior essentially.
So Sigrid, thank you. That's a great question, and I think I want to make that very clear. Radial is a very important signal, but it doesn't solve the issue. Because traditionally, an individual patient data meta-analysis of randomized trial is better than observational data, but is still open to bias. Those were small studies that were not designed to look at difference in long-term survival, and they clearly have there is clear heterogeneity in terms of everything from surgeon experience to postoperative protocol to outcome assessment. So it is reassuring to see that there is a consistent signal in favor of the use of the radial artery, but that doesn't really reassure us that this is the case. You know that, and you are part of the ongoing Roma trial that is going to test the clinical question in a much larger sample size. So I would not say that the evidence is still final. I agree with the fact that the use of the radial arteries is a class 1 level of evidence B at the moment. I don't think we have a level of evidence A for the radial artery. So while I agree that there is a cultural change that needs to happen, it is also true that we need to do everything possible to finally provide the evidence, if this is the case, that the use of multiple arterial grafting improve survival. Unfortunately, the ART trial was, as I always tell, joking, solidly neutral. There was no difference at all. And while I wrote about the high crossover rate and the use of the radial artery, it is also true that at subgroup analysis, the use of the radial artery in the ITT analysis did not change the main finding. And in the per protocol analysis, where crossover is take out of the equation, again, the trial is neutral. It is only when you use that as treated analysis, which honestly is an observational study within an RCT, that you see the huge difference. So I think we are still working on it. And if I may, and I apologize for that, I want to advertise Roma, because there is a UK component of Roma that is starting soon. We are very excited and enthusiastic about it. The trial is currently at 60% of the enrollment. We have enrolled 2,700 patients so far. There is still room for sites that are willing to join the trial. And I think hopefully in 2025 or 2026, when Roma will get to the MACE, the first analysis, the analysis of the primary outcome, we will have a more clear evidence of the role of multiple arterial grafting for capture.
Great. I've got a question that is peripherally related to radial conduit. We obviously have decided that you need to have a high-grade proximal stenosis in order to avoid the competitive flow. For those patients who don't fall into that category, should we be trying to avoid saphenous vein grafts in order to keep the patients away from those poorer outcomes that you've seen? And should we be using the second mammary in those cases?
Well, there is no doubt that the mammary has a much higher tolerance to competitive flow compared to the radial artery. So in a situation like that, I would generally use the second mammary artery, assuming this is technically feasible. And if this is not technically feasible, or if there is a high risk of sternal wound complication, like Bruce Lytle is used to say, saphenous vein is not a poison. So I think you can just use a saphenous vein and be okay with that.
Great. Doesn't look like we have any moderator questions.
I have one quick question for Mario, if that's okay.
Sure.
Yes, please.
Mario, thank you very much. It's a fantastic talk. What strikes me is that, as you said, the outcomes or the benefit is really kind of 5 years onward. And do you think that part of the limitation of the use of the radial artery is that a lot of surgeons are worried about short-term outcomes compared to thinking about long-term benefit for the patient.
You are 100% right. This is probably one of the reasons why surgeons are not using multiple arterial grafting so often. And the reality, Mustafa, is that we don't, unfortunately, we see the patient only at the first postoperative visit, and we don't see them anymore. So we do not know what happened 6 years down the line, but we know very well what happened in our OR if we have a complication. So I think the system should change. The system should reward the surgeon who make the decision to use a more complicated technical solution to benefit the patient in the long term. At the moment, this is not the case.
Absolutely, absolutely.
Great. So we are 15 minutes from the start of the next session. I'd like to thank all of the speakers and especially our keynote speaker for their presentations. And I'd like to thank my moderator colleagues for also participating in the session. Thank you very much. Have a good afternoon.
Thank you. It was my pleasure to be here. Thank you.
Thank you all.
Thank you very much, everyone. Thank you.
Bye-bye.